So we know that myopia is a silent disease, not a problem at the beginning, but if you get more than 6 diopters, you increase your risk, even by multiply by 22, to have to suffer diseases in the future. Okay, so this is something that will arrive in 20, 30, 50 years, but it's very important because we are working for the future of the health of the future of the population. We start with the monkey eye and animal eye. We know that story, but we will remember a little bit about this. My conference will go for the clinical part of the optometrics, what you can do like optometrists. But what is telling us the monkey eye and the cat eye and the other mammal's eye is that our eyes are designed to make what we call emetropization. Emetropization means that we born with some refraction. This refraction will adjust over along of the time to arrive to emetropy. The emetropia will get us around 6 years old, 5 years old, maybe before, sometimes 3 years old. And our cornea, our lens, the shape of the eye will grow accordingly to arrive to emetropia. This is the normal thing in all the human being, all the animals, all the mammals. What we discovered around 4 years ago is if we close the eyes or we impair the vision of that eye, the eye becomes myopic. So the natural way how the eye changes the size is going in the direction of myopia. When the light is not properly arrived to the retina, when the image is blurred in the retina, the eye starts to grow and becomes highly myope. That's the thing we know at the moment. And we know as well that if we impose a blur in the retina in a very young animal, this animal will become myopic or hyperopic. So if we place a +9, for example, on the eye of this young monkey, after several months it becomes hyperopic, and the opposite. If we place a -6, it will become -6. So the emetropization works very well in front of the defocus we have at the moment we warn. L. Smith make a good studies about this, and he make different studies. One was making occluders that impairs the image or reach the peripheral retina, and these young monkeys become myopes. And if he places a lens with a hole in the middle, so the lens is a -3 and the middle is 0, the light passes through the hole and arrives to reach the retina perfectly clear, but not in the periphery. And these eyes became myopes as well if we place a -3. So the peripheral retina dominates the emetropization process. Today, we know that it's not the far peripheral retina, but yes, the mid-peripheral retina. So between around 10 to 25 degrees on the annular retina are the most important part of the retina that dominates emetropization process. And then we need to move to humans to use what we know uh, to help to slow down or control myopia in children. One thing that we look at 20 years ago, it was about peripheral refraction. And peripheral refraction is in general placed in front of the retina for hyperopes in the retina for metropic people and behind the retina for myopic people. And we can see in that graph that in myopic people, the image shell is placed about this retina. So what we don't know, because that was a study of Donald Muti, is if the focus starts it creates the myopia or not, because this is like a child. This is years before myopia appears, and the peripheral retina in the child that will become myope is not very different from the metropic eye. And this is something that we don't know exactly why is happening this. Sorry, this is something.
Okay, sir.
Yeah. Something I
Is there
touched
any problem,
something.
sir?
That's okay right now again. Yeah, you see
Yes,
the
sir.
screen at
Okay.
back. Yeah, sorry.
Yeah.
So everything's okay, right, Kapil? Sound is clear.
Yes, sir. Yes, sir. It's
Okay.
good.
Okay, let's continue. So the thing we are saying is, before to arrive to the myopia, the peripheral refraction for the child that will become myope was not so different that the child that will continue metropic. And it will change dramatically at the moment that myopia appears. So what we don't know really is peripheral defocus in myopes is just a cause, or is the reason, or is a consequence of the myopia. But today we know that this is quietly related. The peripheral defocus is related to the eye growth in the child that they are already myopes. This is something that we are looking at, and we are really not sure at all. But the thing we know is that glasses, normal single vision glasses, are increasing peripheral defocus, hyperopic defocus. Hyperopic defocus means that the image is behind the retina in the periphery. We can see the line for the glasses, the regular one single vision, and we can see here, sorry, without glasses and with the glasses. And we see that the peripheral refraction, hyperopic, the image is going behind. So single vision seems that increases that hyperopic defocus. That is one of the reasons of why myopia increases in child. Another reason for what myopia is increasing in child is what we call the lack of accommodation. The lack of accommodation is not here in the screen, it's in this image, but it's the point where the image is focusing in retina where we are reading, where we are looking at near the point of the image is not focusing retina, is focusing a little bit behind, and that is generating even more peripheral defocus and central defocus. And another thing that is not in that slide is another thing that we know, that in the transient increases of the eye length, when we are looking at near and reading at near, the eye suffers because the position and the accommodation is increasing the axial length around 0.10 to 0.20 millimeters. Sorry, not millimeters, microns. So we know that there's several things that is called, that is involved. That is called the stretching theory. That this is saying that every day looking at near and making some stretching of the eye, it will generate increasing. But the most normal consensus is thinking that is a biochemical cascade that is triggered by the image. At the moment of the image is not clear in the retina, especially in the retina between the 10 to 20 degrees in the periphery. When this is blurred, it starts a chemical cascade inside the retina that tells the eye to grow, increases the collagen to create more collagen and grow the eye. This is the most main idea at the moment, and that's why we are working in the optical interventions, because optical interventions are looking to change the image, change the quality of the image on the retina. And we can do it in the several ways. One way what we are saying that is not useful or is not convenient is the undercorrection, but there in this is something that is happening every day. If you if you correct a child with glasses, after half a year, this child has undercorrection. And after 1 year is undercorrection. And even more is a fast progressor. So almost every child that is using single glasses has undercorrection. There was 2 studies that tell us that the child using undercorrection even increases more the refraction than the child that uses full correction. This gives us the optometric community on the world to say that undercorrection is not good. But there is another study that appeared in China that compare about the amount of the undercorrection and the change in axial elongation, not refraction, not diopters, axial elongation. That is really the most important thing to look at about myopia. And they found no correlation. So there is a confounding factor: the age, the gender, the parents, the time of year, and any other things. At this moment, for my point of view, I believe that is not. We cannot recommend undercorrection, but I really bias that maybe it's not so harmful. In any case, it's the most simple way to correct the child, and it's not the best. The best thing will start with everything that has multifocal, even in glasses, even in soft or GP lenses. So bifocal or progressive lenses has some prevention. There are some studies that tell us about 50% of slowdown myopia, but this was studies made with a very specific sample. Others just tell us about 20% or just a quarter diopter per year and reducing the increase. This is in the screen is the best study about bifocals, the best result study about bifocals, that they reach a good difference between the single vision and bifocals. And the idea about how is working bifocals for myopia control is looking at the peripheral refraction theory, and is saying us that because we are using in the low area the plus power, we are having the focus in the peripheral superior retina, and this could help in myopia control. And that was the following the continuation for the lenses that are today in the world for myopia control. There are peripheral defocus lenses in glasses. It appears in Hong Kong, but it works not really well. And now it appears DMS lenses in Hong Kong that are micro-arrays points with plus power of 3 diopters add everywhere. And the results are pretty cool, around 50% result. So we know that we need to improve the curvature shell, and we need to move the lack of accommodation close to the retina. So we need to move the image shell in front, in the peripheral part of the retina, and center it in the center. That's the idea. The next step is contact lenses for myopia control. The beauty of the contact lenses are we are moving the lenses with the eye, and that provides the correction in place all time long. Of course, Nepal is a country with quite difficult things for contact lenses, and the most spread lenses will be for sure soft ones. GP ones are really interesting because we have less incidence of problems. Microbial keratitis is higher with soft lenses than GP lenses. So if we can fit GP, it will be better. But we know that GP lenses has not effect on axial length. It has effect in refraction. They found a good result. Around quarter diopter slow down myopia per year in refraction, but not in axial length. And that was a very, very known study made by Jeff Walline. And then we say that, from then we say that GP lenses, regular GP lenses has not effect on axial length. They have some effect. So that is why we create new designs in GP lenses. That is a myopic GP, is a design from myself. It's a lens that has a gradient refractive lens. So from the center to the periphery on the optical zone, we have a change in power. We have the far distance vision in the center, and we have an add that is increasing gradually in all directions in the periphery. This lens has a change in peripheral refraction like we want to have. We have without glasses, with a standard GP lens that makes something, is doing something, and with a special GP lens, multifocal GP lens for myopia control. This GP lens is something that we need to explore more in the future. But the thing that the lens that is gaining popularity in the world is the orthokeratology lenses. Orthokeratology lenses, we know that they are changing peripheral refraction. So if we see here, this is the refraction along the retina before doing Ortho Case. So in the center, this mean of the population has 2 diopters of myopia and has similar myopia along the retina. This is nasal and temporal retina. Okay. After Ortho Case is done, we have almost a metropic in the center apical zone, and is increasing the myopia in the periphery. So the image is far from the retina, and around 30 degrees, we have a relationship that is around 1:1. In Ortho K, we know that we are changing the shape of the cornea, changing the epithelium, flattening the center. In this topography, we are seeing the blue color, that it means we are flattening the center area, and the red color, that means we are increasing the curvature of the cornea in that zone. And that means that increasing the curvature, we're increasing the power. Yeah, and this power is generating this change in peripheral refraction that is 1:1. So we correct one diopter in the periphery. Even though if we increase the correction, we increase the high order aberration. And we know from this work from Highorder that axial length is slowing down, the axial length growth is slowing down at the moment we are increasing the high order aberration we induce the eye. So we can induce high order aberrations or with soft multifocal lenses, or with Ortho K, or with multifocal glasses. Here we have a resume our recording about all the studies we have at the moment with soft contact multifocal lenses for myopia control. The first one was Sankari Durg. He used a silicone progressive that is not in the market. And then was John Phillips, that it was present in your first Nepali Congress. Jeff Walline did with, this is a Proclear multifocal lenses, one lens that probably is ready in Nepal. We need to use the maximum amount of ad you want if you want to get a good result with that lens. That is the lens that is in Hong Kong. that is called the rings lens. It's a Carly Lam lens. That is my lens for amyopic. That is a gradient refractive lens. Tom Mahler uses a lens that is not longer useful in the market. It was from Johnson & Johnson, multifocal lens on multiple rings. Alicia Pomeda from Spain and Chamberlain, they make a study with my side lenses. That is a soft disposable lens. Probably will be in Nepal. If it's not ready there, it will be soon. And you can see here that in different studies we get different results, but different efficacy. Usually the efficacy in refraction is higher than efficacy in axial length, and we have different results in general. This is the different results we could have, but in general what we know is all the lenses get some myopia control, and it may make some promising results in the future. In using soft lenses, or especially soft lenses, Ortho Case, and here this is from a book that I recommend to you. That is online book and it's free book that is called Update in Myopia. That is Carly Lam is a co-author, and David Berson is another author. It's a very good book that is free of charge, ready to download in internet. Update in Myopia. So we are going to think about the risk we want to assume. So what we want problems in the future, or we want the risk we have today in microbial keratitis. Microbial keratitis is not good in a child, of course, but how we need to deal with that? We need to deal with that with all the safety counseling. So wash the hands and use the proper solutions. Don't use tap water, and so on and so on and so on. Finally, to look at is the pharmacological products, and this is using atropine. You know that atropine is the drug. You can use that in the hospitals in Nepal as well. If you have a child and you are not able to use contact lenses for myopia control and only single glasses or bifocal glasses, you can put atropine on top. Today we are using combination of treatment. The problem for atropine is the rebound effect. We know that if you are using atropine at 1%, that is extremely high, we have around 70% of myopia control. If you are using atropine at 0.01%, we have less control, around 25%, but there is no rebound effect after when you stop to use the atropine. In this case, they show us that at the moment they are stopped to use atropine, that ones that are putting plus 1% of atropine, they have a very high rebound effect, and at the end they get the same myopia that the child that no use atropine at all. The problem for this study that they show us that atropine 0.01, it will be the gold standard and so on. But the problem for this appears today that we know that atropine is dose dependent. And the LAMP study, that is a very recent study, show us something that we know already. In the ATOM2 study that I show already in the previous slide, 0.01% atropine has a 59% of refraction efficacy, but no efficacy at all in axial length. It means that the refractive efficacy could be for the relaxation of the accommodation, for the paralysis of the accommodation. This study from Jaume in 2018 show us that is dose dependent. Of course, more atropine, higher the diameter of the pupil, are more problem with the blur. But after the 1 year, they found 51% axial length control with 0.05% against 12% in 0.01%. So at this moment, we are increasing the percentage of the atropine, a minimum 0.02%. That will be a little bit here in the middle. Okay, so we need to again to balance the side effects of atropine with the risk of myopia. Again, is risk to benefit. Okay, again, it's the same. It's not an ideal drug. It creates problems. Some child has a relation, some has allergy, and other problems. Okay, so it's not totally perfect. We are going now going into about how you can control the axial the myopia changes along the time. Not all of you will have it, but if you stay in the hospital and this hospital is doing cataracts, you will have a biometer. And the biometer is what we use to know where we are. Here we have a very useful chart. Let's say we have a 10-year child that arrived to your office and they have a 24 millimeters size of the eye. So you know that at this moment, around 15% of the child will have myopia, but this child will become myope in the 87% and high myope in 9%. So you are ready to tell to the parents, we are above the line, the normal line of the metropia, and no myopia is here. We are here, so your child will become myope in the future. Is the moment to start to do something. One thing you need to be understand is the axial length and refraction is not perfectly related. At the beginning, yes. When you have a metropia, you see that an ametropic child could have 22 or 25 millimeters. It could be normal. But after that, we have a line here that shows us that higher the axial length, higher the refractive error. What we correlates better is the relationship between axial length / corneal ratio. So you divide axial length by the corneal ratio, and you have a better correlation, around 70% of the correlation, so that the variation. So you can, if you have the corneal keratometry and you have the axial length, you can know if it's higher than 3, you know that you are in the situation where the corneal radius is not compensating axial length, and you can advise your parents. The advice for the parents will be use the proper correction. If you can do Ortho Case or soft lenses or multifocal lenses in GP lenses, whatever you use is okay. Use atropine on top, but the most important thing is change the attitude. And the attitude is to have the maximum amount of time outdoors, minimum time indoors, minimum time on tablets, computers, and so on, and use a very intense light. We know that there's some correlation between the near work and the myopia, and outdoors is a protective thing for the slowdown myopia. So also we know that the violet light could be very interesting. This is a topic that is full of controversial thing. But some glasses have some protection in blue light. We need to avoid that at the moment until we know that violet light is important or not. So avoid use blue light protector on the single vision glasses on your child at the moment. Here is a compendium of what is useful for myopia control. Ortho Case on contact lenses is the best. Multifocal contact lenses, it will be following it. The time spent outdoors is something you need to add to. Atropine is something that you could add on top of Ortho Case and multifocal, or the progressive adhesion lenses on there. This is the final slide of the presentation, and I guess we are ready for your questions if you want to do some of them, okay? Okay, I have waiting for Kapil. I see here in the
Yes,
chat
sir.
several questions. I could answer this one, or if you want, you can read it out loud, and then I will answer it.
Okay, sir. There is one question from the Amit Kumar Singh. How can we calculate the hyperopic defocus?
Yes. Usually what we do to calculate the hyperopic defocus is we use autorefractometers with a open field autorefractometer. This is something that is not in the optometric places, but one thing you can do is use retinoscopy, and you can use the retinoscopy making the child looking straight ahead with both eye open, and you place you stay at 20 to 30 degrees of axis, you look in one eye using the vertical line of your retinoscopy. And then you could compare central refraction to peripheral refraction. This will help you to know if you have higher or low hyperopic defocus. At this moment, we are not looking at much of this, and you can do another thing that is different. You can use an aberrometer if you have one. That is difficult in the lab. That will tell you if you are having peripheral defocus. But the most simple thing is using retinoscopy. So we have another question here. That is, Kapil, are you there?
Yes, sir. Yes, sir. This is from the Montiza, sir. Sir, I am unable to understand your question. Can you please unmute your phone and ask the question?
Yeah.
Hello, good afternoon, sir.
Yep. Yeah.
Yeah. So, sir, actually, there is a website online by the name of Jake Steiner,
Yeah.
and so the website is nmyopia.org. He's not an optometrist, but
Uh-huh.
what he's really talking about is not correcting myopia too early
Mm-hmm.
and giving a bit of plus at near. It doesn't really correlate to what we do clinically and what we see in the literature. But then he does quote certain nature studies as well.
hmm. Um, I'm not sure which website it is, but I could imagine that. So myopia at this, okay. We have some childs that instead to increase axial length, they strengthen the eye using the peripheral defocus lenses. But the shrinking of the eye, so the axial length is shorter, is made because the choroid is increasing the blood there. Something remains, but in general, when the moment you stop your treatment, the choroid thins again. And that is true that with Ortho Case, after several years of wearing the lenses, maybe because some flattening in the corneal remains forever, maybe because some changes in choroid stay there, I see several children that has less myopia after 10 years than at the beginning, maybe 5%. So this can happen, but this can happen only in I said 5%. And also I see, for example, has -3 before and now they have -2. But I never see a myopia reversed totally. And if I see this, sometimes it could happen for a time and then myopia continue to evolve. So for my point of view, it's not scientific, but I need to have a look at on that website and tell what I think. What I provide in my lecture is all scientific, okay? There is always the idea to stop and reverse myopia, always the idea. But I don't know, I don't know. I'm looking at the website at the moment.
So, sir,
Okay.
thank you so much for answering. Sir, actually, he has also quoted one very good Nature published study, uh,
Mm-hmm.
which is by the name of the progression of corrected myopia. So, it's a very good study, and it shows how early correction of myopia actually increases myopia progression.
Oh yeah,
So,
yeah. That's we say that we are not sure about this. Okay, the only thing we know is if you correct a child with glasses, the myopia will increase. That's what the thing we know for sure. But if you don't correct the child with glasses, there is the studies we have are very poor. So we are not able at the moment to say that if you don't correct the child with glasses, the myopia will not grow and the myopia will stop. What I see in my life is several parents that prefer not correct the child with glasses. And what I see on all that cases are myopia increases. Not at the beginning. When you have a child with around half diopter, three-quarter diopter, one diopter, maybe it's not a problem. I saw child with -3, -4, -5 without glasses. This child is not seeing anything in the classroom, and myopia is increasing very fast every year. Why? We don't know, but maybe but the blur in the retina is something that is increasing the myopia grow. So it's not my recommendation at all. My point of view, if you want to delay at the beginning to put glasses on a child when it's just at the starting point, okay, but not more than half diopters, three-quarter diopter, one diopter. That's not my recommendation at all. All
right,
that
sir.
that
So,
stuff is
so
not
low
scientific.
myopes without astigmatism can be left uncorrected up to a certain point. Maybe.
Oh, maybe, yeah. It's not. It's a recommendation that I should say that is not what what we recommend in general worldwide from the scientific point of view. From the scientific point of view, we are saying that you need to correct as soon as possible, but
I understand, sir.
maybe from the study we have on Beijing, it seems that it will not increase the fastness of myopia at the beginning. So maybe
And
you
and
can
sir,
live without
what
glasses.
and
You
sir,
can.
what about correcting them just for distance and leaving them uncorrected for near? Any thoughts on
Yeah,
those?
that's an old stuff. That's an old stuff we are not doing anymore. I prefer to use bifocals. The problem is, okay, bifocal is more expensive. So parents usually prefer to use the glasses only for far and they take out for near. But in the real world, child will keep the glasses put on the nose all time long. It will not take out the glasses for near because he will not remember. So it's not, it's really not good idea. Not good idea. The if not if you want to delay the time to put the glasses on, recommend outdoors, recommend to proper distance for reading, stay the minimum time possible for computers and so on, but at the end you will be in the moment you will need to put glasses on that child for sure. You will right the moment you will need it for sure. And at the moment you need to put glasses on, I recommend to use or bifocals or progressive lenses, okay, or
Right, sir. Thank you
contact
so much.
lenses.
Thank you.
Yeah,
Gracious. Gracious enough. Yeah.
yeah. There is a question here. Just piloxepine is not. Yeah, Camille, you want to read some questions if you like?
Okay, sir. I guess we have answered most of the question. Uh, I'm checking the questions if there, and if anybody have the question, you can unmute
Hello,
yourself and ask the
hello,
question.
Yeah.
Hey, yes, please,
hello.
sir. Go ahead, sir.
Yeah. Hello,
Yes, sir.
Dr. Fabre. Thanks for your insightful presentations and talk.
Yeah.
I have just a small question that as we know that there is no single promising method uh, in correcting this myopia, in the treatment of this myopia completely.
No.
Would you please recommend any guidelines or the indications to practicing optoms? I think if you have any specific guidelines or indications to practicing
Hmm.
optometrists, I think that would be much help to the practicing optoms.
Yeah. So I will tell the way I will do it in my office, and also you can download that book. You can download two things from internet very easily. One is called the book. That is 1 second. I will look at that book. Yeah, 1 second. Is updates on myopia. I will share in the screen. 1 second.
Okay.
Yeah, 1 second. How we share this screen for you? Okay, this is. I will share out. 1 second. Uh, yeah.
Yeah.
Are you seeing that? No, not seeing yet. Oh, I could change the screen. Okay. A moment. I need to. Maybe I need to. Okay. Yeah. Okay. I see. Okay. Yeah. Okay. In theory, it's coming.
Yes, sir. It is visible.
Can you see it at the moment or not?
Yes, sir. Yes, it is visible.
Yeah. Okay. This book. Okay. This is free. Open access. Very interesting book. Okay. You have everything inside to read. Very new, and you have all these things. Okay. This is the thing we can share. And another thing you can download from internet is the EAM papers. This is this book, and this is these articles. So it's the interventions for controlling myopia. This is free. You can download from where? From Investigative Ophthalmology and Visual Science. And there is a series of 7 papers, very compelling about this. Okay, the spectacles, you have everything, and you can read everything. But now, okay, now about this. First thing is look at the child. It depends of the age. It's not the same a child very young, 5 years, 6 years, 7 years old, that a child that has 12 years old, 15 years old. Nothing, it's not the same. So younger the child, less things we can do. We can do is outdoors, maximize outdoors, minimize indoors, minimize books, minimize laptops, minimize phones. Also, we can use atropine in any age if you are in the hospital or you are allowed to use it, but you need to be careful with atropine, of course. Now, we can do glasses or we can do contact lenses. If we are it depends of the parents. If the parents are listening to us, the parents are ready to it. Some parents are not ready for any treatment. They don't understand at all. So you need to wait until the child becomes more myopic. Some parents will believe to you and will follow you. So some parents will start to follow you at the beginning. Now, glasses or not glasses? Yes, of course. We can delay the use of glasses at the beginning when it's a very low amount of myopia. We can do anything else. Yes, we can delay this. We can use sometimes small plus power lenses for near. Okay, that helps sometimes, maybe 10%. Visual therapy can help around 10% as well. There's a question there, but visual therapy, in my experience, helps a little bit to delay, but it's not helping at all for myopia control and long term. So you can do plastic lenses for near visual therapy, stay outdoors, all those things that could help. Maybe not put the glasses, okay, at the beginning, but when myopia starts to be a little bit higher, you will need to use or glasses or soft contact lenses. So if you can do soft contact lenses or GP lenses or Ortho Case, go there. If you are not able to do this, go for the bifocal glasses. Bifocal glasses, you need to put an ad that is ideally minimum ad. It will be 1.5 diopters and it will be high, so close to the mid size of the pupil for the child, to be sure that the child will use the ad in near, and you will sure that when it's looking far, the vision for near is passing through the bifocal area to the upper zone of the retina. This will be the way I will do. I will work. I will work for the starting for the best. The best is Ortho Case. If not, we will use our soft or GP lenses. If it's not, we will use bifocal. If it's not, we will use single vision, and we can use atropine on every moment of that. To use atropine, it is if you are only allowed to use glasses for far, single vision, then I will go for there. If you are using other systems, wait for 1 year and look if the myopia is increasing or not. If we need to divide myopes in low, medium, and high progressors. Myopia for progression for less than half diopter per year, that's okay. Myopia increasing from between half to 1 diopter, you need to do something there. Myopia increasing more than 1 diopter, you need to do everything you have in your hands because the myopia is going very fast. That means that depending on the age of the child and depending on how fast is increasing myopia in that child, you need to work in one way or another. The most important thing is you need to have in your mind what is useful here. And this is the last that's a slide in my presentation I showed to you that shows which treatment we have. And this is what we need to have in mind to help your child. That is basically what you need to do. Okay. Okay, we need we can move for another questions. There is someone that is asking about syntonics therapy. Syntonics is something that is using for other things, but not for myopia. Another question here, a psychoplegic refraction for half diopter will correct with glasses. Yeah, this is something we answered already. The best tip, this kind of bifocal, it should be the line flat, the bifocal that is one line to another size. Okay. There is a book from Andy Rosen. I think it's not this exact healing your race with Chinese medication. Well, this is also the same thing. We will find plenty of books over there, plenty of internet things about healing your eyes without glasses and reverting myopia and all the things, or making yoga or Chinese or plenty of things. There is this for 40 years. The first that invented that was that Dr. Bates in US in the 1920. But from them, see, I never found something that it really worked for this. Okay, so I really don't know about this. No, from the scientific point of view. Okay.
Okay, sir. There is another question from the
Yes.
Suez Acharya. If we are prescribing the bifocals, in your experience, which type of bifocals have better
Yeah.
results, or we can
Yeah.
prescribe any type of bifocals?
Sure. I say this just already. So the bifocal you should use is executive one. You know which one I'm talking about? Executive one, Kapil?
Yes, sir.
You know which kind of bifocal is executive
Yes.
or not?
As yes, sir. It is the type of bifocals that we
It's also,
use.
some people also call it Franklin bifocal,
Yeah. Yeah.
the one in the
Oh,
line.
sure. You need anyone that has a wide area for near is suitable for that. Okay. Anyone do have
Yes, sir.
as big area for near, but you need to place it high.
Okay.
Okay, so I guess I think it's time to start. Yeah, executive. That's right. It's time. We can answer the last question and start to finish our meeting at the moment.
Okay, sir. Okay, sir. So there is another question.
Yeah, the
How
alternative
important
is
is to monitor the axial?
refraction.
Yes. Uh, uh, there is a one question, sir. How important is to monitor the axial length in Ortho Case wearing size, or is there any alternative if there is no biometric measuring instrument is available?
Yeah. Okay. Yeah, refraction. The problem is I told you that refraction is not well related with axial length. Why? Okay, why we are talking about axial length? We are talking about axial length because the problems in myopes comes from retina, and problems in myopes comes from eye that is too long and retina stretches, and the retina makes thinner. Then you have problems of retinal detachment or macular degeneration and long term. So the problem is in the retina, in the back. That's why we are talking about axial length, because the refractive change of the eye is not always correlate to the axial, to the size of the eye. But if you have nothing else, look for the refraction. Okay. But I show here this that it could be interesting to you. You can see here a formula. So if you have in this formula, if you have the refraction of the child and you have the corneal radius, you can derive axial length from that formula. Just need I didn't make the calculation in the different, but it's a very simple formula, so you can know in the 70% chance the axial length of the eye just with the refraction and the keratometry. You could use this. The other way you can do is just look the retina, the fundus. If you have a OCTs or machines to measure, to look at the posterior pole, if not, you look directly with a ophthalmoscope and look the retina, how the retina is changing. When you have a myopia that is start to become worse, you will start to see changes on the retina, and this is telling you that you are reaching the dangerous point. So before this, we are working. When we are right there, it's a must to work to slow down myopia in that child. So look at the retina and look the refraction. Okay. Thank you. De nada. Mutuza. Okay, gentlemen, I guess it's time to finish. It's really a pleasure to be with you, with my Nepali friends.
Yes, thank you so much, Jaume sir, for such an informative session, and also thank you to all the attendees for the participation and for their passion. Well, I guess we have answered many of the queries, and considering the time limits, here I announce the closure of the discussion. Before ending the today's session, I'd like to express my sincere gratitude towards our presenter and all the attendees. Also, I would like to appreciate for all the helping hands for this program. Herewith, I am at ending for today session, requesting all for drop your review and feedback. Stay safe, keep in touch. Thank you so much.
Thank you so much, everyone.
Thank you, sir.
Hopefully we will see together, see the faces in next future when all the coronavirus goes away, okay?
Yes, sir.
So thank you so much. Namaste.
Yes, sir. Thank you so much, sir. Have a good time, sir.
Have a good time. Bye-bye.